In 20 years of treating patients over 60, I have watched hearts weaken, rhythms fall apart, organs quietly shut down. And some of the worst damage I've seen, the cases that kept me up at night, not bad diet, not smoking, not genetics. It was caused by medications, pills prescribed with good intentions that were working against the heart the entire time. I'm Dr. David Okafor, internal medicine, over 20 years treating seniors with heart conditions, high blood pressure, the whole range. Here's something that doesn't get talked about enough. The average American over 65 takes 4 to 5 prescription drugs at the same time. Some take 8 or more. Every one of those drugs was tested on its own, approved on its own. But what happens when you combine 3 or 4 of them in a body that's already filtering more slowly, metabolizing at a reduced rate? That question almost never gets answered in a standard appointment. Let me tell you about someone I'll call Harold. 74 years old, retired mechanic from Fort Worth, sharp guy, careful about his health, walked 2 miles every morning, watched what he ate. Harold came to me after his second cardiac event in 18 months, and he was exhausted, not tired, exhausted. The kind that doesn't lift after a full night's sleep, muscle cramps waking him at 3 in the morning. His thinking had slowed in ways that scared him. 3 doctors, same answer every time. Harold, you're 74. This is normal. 2 years of that. When I reviewed his full medication list, every drug, every dose, I saw the problem within 5 minutes. Not one problem, a chain. Each pill quietly stripping away something his heart needed and feeding the damage into the next one. We'll come back to Harold, because how his story ends is the reason I'm making this video. Now, before we get into the 5 pills, drop your age in the comments and tell me how many prescriptions you're on right now, whether it's 2, 5, or 8. I read every single one. Today, 5 specific medications that millions of people over 60 take every single day. I'll tell you 3 of them right now. Statins, NSAIDs, that's your ibuprofen, your naproxen, and proton pump inhibitors, the heartburn pills. If you're taking any of these, this video is for you. And 2 more that most physicians, myself included, had serious blind spots about for years. Number 5 especially. That one changed how I talk to every patient over 60. But here's what nobody explains. These 5 pills don't just work on you one at a time. They interact. They compound. And understanding that chain, that's the part that could change everything. Statins. If you're over 65 in America, roughly 1 in 3 chance you're taking one right now. Atorvastatin, rosuvastatin, simvastatin, the names change. The mechanism is the same. And I want to be clear about something. Statins save lives. For established heart disease, the evidence is real and I've seen it firsthand. I'm not here to tell you statins are bad. I'm here to tell you what statins take from you while they work. Statins block something called the mevalonate pathway. That pathway doesn't only produce cholesterol, it also produces CoQ10, coenzyme Q10, and that distinction matters more than most people realize. Think of CoQ10 like engine oil for your heart cells. Without enough of it, the engine still runs, but it runs rough, and over time, it wears down. Research shows that statins can drop your CoQ10 levels by 30 to 50%. Let that land. 30 to 50% depletion in the organ that needs it most. What does that look like in a real person? Fatigue that doesn't respond to rest. Muscle weakness that your doctor blames on aging. A mental fog that wasn't there 2 years ago. And in a significant number of patients, measurable reduction in cardiac function. Harold had been on a high-dose statin for 2 years. 2 years of his heart running below capacity. And nobody checked. But CoQ10 isn't the only thing statins take. Actually, I should back up for a second. The mevalonate pathway, that's a $10 word for something simple. It's a production line inside your cells. Statins shut part of it down to lower cholesterol, but CoQ10 gets caught in the crossfire. And here's the part that's been in the medical literature for over a decade, but almost never comes up in the prescribing conversation. Statins can block the glucose transporters on your muscle cells. Think of it like jamming the door so sugar can't get in. And they can wear down the beta cells in your pancreas, the ones that actually produce insulin. 2 hits, 1 pill. A major meta-analysis, 13 trials, over 91,000 people, found that statins increase your risk of developing type 2 diabetes by 9%. 9%. And with higher doses, that number climbs. So you might be thinking, but my doctor says my cholesterol is dangerously high. Am I supposed to just stop? No, that's not what I'm saying. What I'm saying is the conversation about what statins take from you should happen at the same appointment where they're prescribed. And for most people, it doesn't. Here's what to ask. Should I be supplementing CoQ10 alongside my statin? The Q-Symbio trial, a randomized controlled trial in heart failure patients, showed that CoQ10 supplementation led to significantly fewer major cardiovascular events over 2 years. That's real data. The dose used in that trial was 100 to 200 milligrams daily, worth asking your doctor if it fits your situation. And the second question, has anyone checked my fasting glucose trend since I started this statin? If the answer is no, that's the conversation that needs to happen. Now, remember what I said about these pills working as a chain? Your statin just lowered your CoQ10. Your heart muscle is already working harder than it should. Keep that in mind, because the next pill makes it worse. This one catches people off guard. It doesn't look like a heart medication, and that's exactly why it's dangerous. Ibuprofen, naproxen, diclofenac, the NSAIDs, over-the-counter, cheap, in every medicine cabinet in America. Most people figure it reduces inflammation. Inflammation is bad for the heart, so it's probably fine. Maybe even helpful. That logic is exactly backwards. NSAIDs block something called COX-2, and COX-2 produces prostacyclin, your blood vessel's natural protector. Think of prostacyclin like a non-stick coating on the inside of your arteries. It keeps them flexible. It prevents dangerous clotting. Block COX-2 and you strip that coating off. At the same time, regular NSAID use raises your blood pressure by about 3 to 5 points on average. Sounds small, but after 60, with arterial walls that are already less elastic, that chronic bump adds up over years. Stroke risk accumulates quietly. The FDA put a black box warning on NSAIDs in 2015, not just for stomach bleeding, specifically for heart attack and stroke. It's on the label right now. Harold was taking ibuprofen every single day for 2 years, for joint pain. His doctor knew. Nobody flagged the cardiac risk. So what instead? For chronic joint pain, ask about topical NSAIDs. Diclofenac gel, same anti-inflammatory effect. Delivered locally, about 90% less reaches your bloodstream. For chronic background inflammation, curcumin with piperine has real evidence behind it. And omega-3s, 2 to 3 grams of EPA and DHA daily. The REDUCE-IT trial, published in the New England Journal of Medicine, showed a 25% reduction in major cardiovascular events. That's a number worth knowing. Here's the synergy picture. If you're on a statin and taking daily ibuprofen, your heart is being drained of CoQ10 on one side and stripped of vascular protection on the other. Topical gel plus omega-3 addresses both without adding another pill to the pile. Before we move on, and the next 3 are where this gets harder to hear. Quick question for you. Type 1 in the comments if you're taking one or more of these pills yourself right now. Type 2 if you're watching because someone you love is. I want to know who I'm talking to because the next 3 pills are where this gets personal. This is the one that took medicine an embarrassingly long time to recognize because it looks nothing like a cardiac drug. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole. Roughly 15% of American adults take one, many for years. some for decades. So why would an internal medicine doctor care about a heartburn pill? Because your stomach acid isn't the enemy, it's a gatekeeper. You need that acid to absorb vitamin B12. Block the gatekeeper long term, and B12 absorption drops. Not a little, almost completely. And here's why that matters for your heart. B12 is essential for metabolizing homocysteine, an amino acid that, when it builds up, directly damages arterial walls. Elevated homocysteine is an independent risk factor for cardiovascular events, comparable in some studies to high cholesterol, and it's almost completely ignored in standard workups. Research published in JAMA found that long-term PPI users have B12 levels roughly 30% lower than people who don't take them, in a population that's already losing B12 absorption naturally with age. After 60, your body produces less intrinsic factor, the protein that helps absorb B12, a drug-induced deficit on top of an age-related one. What does B12 deficiency look like? Fatigue, for one, memory problems that you chalk up to aging, and then a tingling in the hands and feet that creeps in so gradually you barely notice it at first. In severe prolonged cases, irreversible neurological damage from a heartburn pill taken for 10 years because nobody checked levels annually. But PPIs don't stop there. They also deplete magnesium. And for your heart, magnesium regulates the electrical signals that keep your heartbeat steady. Deficiency is directly linked to arrhythmia and to those cramps at 3 in the morning. Harold's B12 came back critically low, his magnesium at the bottom of the normal range. Technically in range, so nobody acted on it. The fix. For B12, sublingual methylcobalamin, 1,000 micrograms, under the tongue, bypasses the absorption problem entirely. No stomach acid required. For magnesium, chelated form, glycinate, 400 milligrams daily. Far better absorbed than the magnesium oxide you find in most cheap drugstore bottles. And if you're on a PPI long-term, ask your doctor about a plan to eventually taper off. Don't stop abruptly. There's a rebound effect. Acid surges back worse than before. Now, step back for a second. 3 pills. Harold's CoQ10 is depleted, his vascular protection is stripped, his B12 and magnesium are blocked, all 3, simultaneously, for 2 years. Each specialist saw their piece. Nobody asked what the combination was doing over time. 2 more pills, and these are the ones that changed how I think about the advice I give. Quick pause. If what I just described, 3 medications quietly draining your heart of what it needs, each one making the next one's damage worse, if that connected some dots for you, take 1 second and hit subscribe. It genuinely helps this reach more people who need to hear it. Now, you might be thinking, this sounds like every medication is poison. That is not what I'm saying. These medications save lives. I've prescribed them, I've seen them work. What I'm saying is that every medication takes something while it gives something. You deserve to know both sides. That's the whole point. Warfarin, around since the 1950s, still one of the most prescribed blood thinners for patients over 65, atrial fibrillation, deep vein thrombosis, mechanical heart valves, standard care for millions. And it works. It prevents dangerous clots. It prevents strokes. I'm not disputing that. But here's what the 7-minute appointment almost never covers. Warfarin works by blocking vitamin K, but there are 2 forms of vitamin K, and warfarin can't tell them apart. K1 handles clotting. That's the one you want blocked. But K2 does something completely different. K2 activates a protein whose entire job is to keep calcium out of your arterial walls and send it to your bones instead. Think of K2 like a traffic cop directing calcium. Bones, yes. Arteries, no. Warfarin takes that traffic cop off the road. Without K2 activity, calcium drifts. It settles into vessel walls. Arteries become rigid and calcified, like old pipes slowly filling with mineral deposits. I've seen what heavily calcified arteries look like in imaging. Or let me put it another way. because the pipe analogy only goes so far. When calcium hardens in your arteries, it's not just narrowing, it's making the walls brittle. Treatment options shrink, outcomes get worse. A study in the Journal of the American Heart Association found that long-term warfarin users show significantly more coronary artery calcification compared to patients on newer blood thinners that don't. Does this mean you should stop warfarin? Absolutely not. Untreated atrial fibrillation carries roughly a 5% annual stroke risk. That's not a risk to dismiss. But it does mean asking 2 specific questions at your next appointment. First, given newer options today, apixaban, rivaroxaban, is warfarin still the best choice for me? These newer blood thinners don't have the same K2 interference. Second, has anyone measured my coronary artery calcium score? A simple low-radiation CT scan, one of the most underused cardiac risk tools that exists. One scan tells you what's happening inside your arteries right now. And here's a synergy point that almost nobody connects. If you're on warfarin and calcium supplements, that's pill 4 and pill 5 working together to calcify your arteries from 2 different directions. That combination needs a serious conversation with your doctor. Which brings me to pill 5. And this one is hardest for me to talk about. Not because the science is complicated, because I recommended it myself, for years, to patients who trusted me. Calcium supplements. If you're a woman over 60, there's a good chance at least one doctor has told you, take calcium for your bones, 1,200 milligrams a day, take it with food. So routine it barely registers as medical advice. It feels like common sense. I said those exact words to patients for the first 15 years of my practice, every time, reflexively. 68-year-old woman with early bone density loss, calcium and vitamin D, 1,200 milligrams, take it with food. Next patient. Then I read a meta-analysis published in the British Medical Journal that stopped me cold. 15 randomized controlled trials, nearly 12,000 patients, calcium supplementation without K2 and D3, linked to roughly a 30% increase in cardiovascular event risk. 30%. For some of those women, the supplement may be doing more harm than good, and the data suggests the risk is not trivial. The calcium paradox. Supplemental calcium enters your bloodstream as a sudden concentrated surge. Your body doesn't know where to put it all at once. And one place it ends up, arterial walls. Same calcification we just talked about with warfarin, but this time driven by the supplement itself. You take a pill to protect your bones. It calcifies your arteries instead. And if you're already on a statin draining CoQ10 and a PPI blocking the magnesium that steadies your heartbeat, now you're adding calcium into arteries that are already stiffening from 4 directions. That's not one pill going wrong. That's the whole chain arriving at the same destination. Why haven't the guidelines fully caught up? Reversing a recommendation given to tens of millions of people for 20 years is, or more precisely, it's institutionally complicated. Liability questions. Industries built around calcium sales. Easier to add a quiet footnote than to say out loud, we got this wrong. When I read that BMJ data, really sat with it, I thought about every patient I'd said those words to. Every woman taking that supplement every morning on my advice. I felt responsible, not guilty, because I couldn't have known what I didn't know, but responsible for making sure the next patient gets the complete information. That is why I'm making this video. If you're on calcium supplements, don't stop abruptly, especially for documented bone density loss. But bring this to your doctor. Should I be taking K2 and D3 alongside my calcium? For most patients, the evidence-based answer is yes. K2 as MK7, 100 micrograms daily, D3 minimum 2000 IU, and wherever possible, dietary calcium first. Dairy, leafy greens, small fish eaten with the bones. Supplements to fill gaps, not as the primary source. K2, D3, and dietary calcium instead of a high-dose supplement on its own. That's the combination that protects bones without hardening arteries. Okay, so what do you actually do with all of this? Before your next appointment, write down every medication, every supplement, every dose. Then write 3 words at the top. What am I losing? Statins, CoQ10, NSAIDs, vascular protection, PPIs, B12 and magnesium, Warfarin, K2, calcium supplements in the wrong conditions, arterial flexibility. None of these trade-offs mean the medication is wrong for you. They mean the conversation is incomplete without them. Now let me come back to Harold. After reviewing his full list, I sat with him for 40 minutes, not 7, 40. Every drug, every dose, every interaction. I laid out the chain, how each depletion fed into the next. Then we made changes. CoQ10 200 milligrams daily. His B12 came back critically low. Sublingual methylcobalamin started immediately. Chelated magnesium added. Daily ibuprofen switched to a topical diclofenac gel. Same anti-inflammatory. Fraction of the systemic exposure. His GP worked on a gradual PPI taper. K2 and D3 added alongside his existing calcium. Nothing dramatic, no new surgery, no breakthrough drug. We simply stopped depleting the things his heart needed to function and replaced them. That's all. 6 months later, Harold called. He said, "Dr. Okafor, I feel like myself again." For the first time in 2 years, the exhaustion was gone. The 3 a.m. cramps stopped within the first month. Cardiac follow-up showed improvement. His cardiologist called it encouraging. His GP was puzzled, said the numbers didn't fit the expected trajectory. But nothing had changed except the full picture finally being addressed. The medications on this list are not villains. The doctors who prescribe them are not negligent. The problem is a system that rewards the prescription but has no mechanism to reward the follow-up. No time for, what is this combination quietly doing over the next 2 years? Each specialist sees their piece. Nobody connects the chain. You might be thinking, how do I even bring this up without being dismissed? Start with the list. Write down every medication and every dose. Write, what am I losing at the top? Hand it to your doctor. You're not challenging them. You're asking for the complete conversation. And I'll tell you something. Most good doctors will respect that. They want to have that conversation. They just don't have the time built into the system for it. You bring in that list, you're giving them permission to slow down. If this helped you see something you hadn't seen before, send it to someone managing multiple medications. A parent, a spouse, a friend who's been told their exhaustion is just part of getting older. It may not be. Everything I've shared is grounded in published research and my clinical experience. Your situation is unique. Bring these questions to your doctor before making any changes. And if you want to know what else your medications may be quietly affecting, I made a video on exactly that. I'll link it right here. Take care of your heart. It's been beating for you every second of your life without ever asking for a break. The least we can do is pay attention.